Hey, good afternoon, everyone. John Snyder here on another Thursday afternoon for Newton-Wellesley Medical Group Lunch and Learn. We are really excited to welcome Dr. Abigail Love. Abby's going to be talking to us about All Bodies Welcome, offering inclusive care with health at every size. Thanks, Abby. If you can go to the next slide. Before her talk, we want to go ahead and just tease upcoming Lunch and Learns. Next week, we have sudden hearing loss, and then our March presenters. As you can see, we have a nice wide array of talks coming your way. As a reminder, these talks are all up on the intranet as well as on YouTube. And you can go ahead and search for any talks over the weekends, or if you have some time, if you heard a good talk, I heard someone talk about, it was a good one, you want to go ahead and recapture them, you can search them as well. We've been doing this now for close to 2 years now, so a whole bunch of talks are up there. Next slide. A couple of things we want to make sure our providers are aware of. Our physician care concierge service continues to be available. This is an amazing service for you to just sign up and get recommendations for things that you might need, such as the best gift for, we have Valentine's Day coming up, so the best gift for your wife or your mother or your daughter for Valentine's Day, or how to figure out who's going to shovel your walk at the next time we get 24 inches of snow, or who's going to fix your car after your teenager runs into your garage. All these things are possible and ways that concierge can help you. They will vet these services and via email, which is not too intrusive, send you 2 or 3 recommendations. This is a free service, plus there's +1 access. Please take advantage of it while it's available. You can easily sign on community.circles.com using NWH. All NWH providers are available. Next slide, Abby, please. And then we have a seminar going live starting next Wednesday. We are really excited about this. We have heard folks wanting to know about wellness. We're going to be focusing on financial wellness through the early spring on Wednesday evenings. Feel free to grab dinner and to listen to a talk from New York Life. The first talk will be on the blueprint for financial success. This is geared towards all providers. Please come in and join us. This will also be recorded if Wednesday at 6:30 does not work for you. This is going to be a great series, and we hope you will participate. Look for an Outlook calendar, just like these Outlook calendar invites should be in your box. Next slide. And then we want to remind folks that through June 1st, that the Shipley Fitness Center is now open. Please feel free to give it a try. The Shipley hours are really widespread, opening at 4:30 and staying all the way open to 10 o'clock, Monday through Friday. So it does fit the need of any shifts. If you're in early or need to stay late, we're also open on the weekends. All you need is an active badge. We do request that you fill out a health appraisal form before you start working out at the Shipley. And it's an amazing place to get a good workout in, either before or after your shift. And please take advantage of it. Any questions? Daniel Destin is our lead manager over there, and he is very willing to help out. And I believe that's the last slide. Abby, take it away. Thanks.
All right, so I'm unmuting myself, and I am frequently referred to as Abigail because of Epic and email, but I do like to be called Abby, and I use she, hers pronouns. So a little bit about me. I'm a family medicine physician. I graduated residency 14 years ago. I joined Newton-Wellesley Hospital in 2020, and I work at the primary care office at 978 Worcester Street, AKA Newton-Wellesley Primary Care, Wellesley Hills, but frequently known as 978 on the mean streets of Wellesley and Newton. I previously worked for Cambridge Health Alliance, and I started my career in the National Health Service Corps at Cook County Hospital in Chicago, Illinois. In addition to being a doctor, I have my MPH in community medicine with research focused on harm reduction and needle exchange for injection drug users. And I have a background before I came to do purely clinical work at Newton-Wellesley in curriculum design, med ed, medical simulation, and interprofessional training. And so I say that only to say that you can take the girl out of med ed, but you can't take the med ed out of the girl. And so I start every talk that I gave when I was teaching simulation with the basic assumption that I learned from the Center for MedSim in Boston. And it seems a little bit lame, but I've learned that it's really important to state this whenever we talk about things that might bring up some feelings. And my basic assumption is that I believe that everyone participating as Lunch and Learn is intelligent, capable, cares about doing their best, and wants to improve. Otherwise, you wouldn't be taking time out of your busy day to listen to this. It's important for me to say that out loud and to be explicit because some of the stuff that I'm saying today might move you out of your comfort zone. And I think that's okay. When we move out of our comfort zone, when we're feeling and learning at the same time, that's where the magic happens. Now, I certainly don't want you to be so angry you're like smashing the screen, and I don't want you to be so shut down you turn it off and walk away. So we want to stay within what I would call a window of tolerance. But I do want to just warn you that I'm talking about some topics today that might bring up some things for you in your personal life, in your professional life, and it's okay. I expect that you might have a feeling. I also just want to say that I am not an expert on this. I am primary care trained. From my MPH onward, I've always worked with kind of inclusive radical care in terms of harm reduction. But I am a full-time primary care doctor. I don't have a fellowship in obesity medicine. I am not trained in anything in particular about the care of folks with eating disorders. However, I have, since I came to Newton-Wellesley, developed a very large panel of patients that's very size inclusive, and a huge amount of patients who are dealing with an eating disorder are recovering from an eating disorder. And so because of the generosity and the trust of my patients, I have been working very hard to evolve along this topic of how I handle weight within my clinical practice. I also say I'm not an expert because I'm learning all the time and I'm evolving. I'll probably screw up at some point today and say something and put my foot in my mouth, and that's okay. I ask you not to call me out. I won't call you out. Call me in. Bring me in and remind me of how I can do better with our language or better with what I'm framing, and the same for you guys. I also am aware that we have very limited time, and people have written PhDs and developed whole careers on these topics. So I'm not going to be talking about best practices in the care of eating disorders. I am not going to be able to talk about like the neural pathways and all of the biochemical pathways of adipose tissue. And I'm not going to talk about pharmacology today. I know that these are all rich and interesting topics, and so my lack of focus is not because they're not worthy, it's just outside the scope. So when I have about 25 minutes to talk to a group of busy clinicians, I really want to hold the idea of me kind of blowing on a dandelion. And I'm just going to give you a set of ideas, talk about kind of 3 ideas within the idea of weight inclusive care, and I'm blowing dandelion seeds, and maybe one of these seeds will plant a curiosity, will change a small practice for you, will have you go and read something else or attend a new CME. So my only goal is to get you more curious about how we can do better with our care. So take a deep breath, center yourself, and I want you to focus on the patients I put up. I just grabbed these from the internet. But I really want you to think about our patients that we care for, especially our patients who have the bravery to come into our office in a larger body. And why do I say bravery? It's because when someone in a larger body steps into the medical world and steps into medical office, they are facing diet culture. They are addressing the diet culture that they've been addressing in every aspect of their lives, and medical office is no different. Diet culture is a collective set of social expectations that tell us that there's one way to be, and there's one way to look and one way to eat. And this is the key part, that we are a better person and that we're more worthy if our bodies are a certain way. And sometimes I use this metaphor of fish swimming, and they say, what's water? We sometimes can't even recognize diet culture because it's all around us. We learn early, and then we keep getting the message as children and onwards that certain bodies are worthy of praise and worthy of protection, and others deserve judgment or harm. we consider just for a moment, just think about these messages that we received as a child from family, friends, doctors, gym teachers, school nurses, and our larger community about what is normal, what bodies are attractive, and what bodies are healthy. Years of lived experience have shaped all of our lenses, and these are the lenses that we relate to our bodies and then the bodies of those that we care for. And so diet culture manifests in us when there's parts in all of us that believe that it would be irresponsible or even dangerous to act as if a larger body could be okay the way it is. And that comes up in our personal life, but it can also come up in our practice. So diet culture can manifest in how we frame medical outcomes for patients with obesity, where it becomes about a focus on individual willpower rather than the structural forces affecting their choices and the way their bodies move through the world. So what is weight bias in medicine? Weight bias in medicine is assumptions that people living with overweight and obesity are lazy, incompetent, lacking in willpower, self-discipline, and particularly that they're not motivated to improve their health. Some of these words might land pretty hard. They're pretty negative, the lazy, the incompetence. And if we go to the research, and it's particularly fascinating when they do kind of text analysis of charts, when you look at how patients who are living in larger bodies, patients with obesity, how they're described and what adjectives are used when they are written about in notes, even if you're not using these explicit words, a lot of times there's negative connotations to the descriptors that are put in the chart. And another basic assumption I have when I'm speaking about diet culture in medicine is that weight bias itself may pose a greater threat to an individual's health than their increasing BMI. Longitudinal evidence shows that irrespective of the baseline BMI, adults who report experiencing weight discrimination have a 60% increased risk of death. Up to 55% of women who live with obesity report delaying or canceling an appointment if they anticipate the need to be weighed during the consultation. I've had women tell me that they had to drive 2 or 3 times to my office and sit outside in the parking lot crying before they could even get into the office. And these are women who haven't been inside a medical office for 7 to 10 years. And evidence shows that women with overweight or obesity admit to delaying or avoiding routine health maintenance like breast exams, PAPs, because of fear of judgment when needing to expose their body. So how do we change the frame of the way that we approach obesity? And one of it is, like I said, is holding the structural. So rather than looking at the individual patient and framing their weight and their what we think of as weight-related outcomes as a lack of individual willpower or individual effort, if we hold the structural and widen the frame to look at someone in a larger body and think that their health outcomes are largely a result of a history of weight cycling, which means rapid up and down weight gain and loss, the stigma they live with in larger society, intersectional drivers of weight. We know that weight is not a single issue, that it is there's a lot of gender issues leading to it, racism, patriarchy, all the things, homophobia, and that's driving the way that their body moves through the world and the outcomes they're facing. And the thing that I want to focus on today is how inadequate and harmful healthcare is actually leading to worse outcomes for people in larger bodies. So how are we as physicians complicit with weight bias in medicine? This has been studied ad nauseum, and there's a wealth of information that shows that physicians report feeling more negatively toward overweight patients. Physicians spend less time with patients with obesity, but order more tests. Physicians build less rapport with patients with obesity, and the physicians actually just when they've done analysis of like exams, the physicians actually just touch fat people less when they examine them. But probably the thing that patients bring up over and over again in the exam room with me and on all of the message boards and in social media and when they're talking to their support groups is the lens through which we view our patients. And it is solely through the lens of weight. I saw this joke going around the internet, but a lot of patients will say it's true that people come in with all types of diseases, and even if they are actively suffering from something, the first thing that happens without even asking permission is weight talk and being advised to lose weight. So here's a few that I pulled just to kind of give some testimony. There's an interesting Twitter subthread called Diagnosis Fat, and this comes up a lot. A patient who saw a doctor and they were having neck and shoulder injury car accident, but they said it was because that she was fat, so she should lose weight. Or a doctor who, was trying to talk to a patient about weight loss, hypertension, diabetes, which they didn't have, when they had a fever of 102 because of influenza. And then I put up this slide about Wellbutrin because I want to talk to you about one of my own patients who was dealing with a lot of anxiety and some depression symptoms and really having, disruptions in their work and their relationships and their wellness. And they went to see a doctor who said they should be on Wellbutrin. And the only thing they said is you should take this because it'll make you lose weight. It'll suppress your appetite. They didn't say that it was going to address their depression. They didn't talk about the other side effects of Wellbutrin. They didn't say what the dose was. And they didn't mention that it was a stimulant and might actually activate some of their anxiety symptoms. And so she sat in front of me, with this Wellbutrin prescription, having not started it, having gotten worse with her mental health, because she didn't trust it was the right thing for her, because the only thing that was said to her was that she would lose weight with it. And she thought it was a weight loss drug and not something for her mental health. And so this really crystallizes for me the dilemma of ethical care delivery. And it's that, as healthcare providers and as physicians, as nurse practitioners, PAs, nurses, that we're responsible for adhering to the ethical principles of care, such as autonomy, beneficence, and non-maleficence. But the dominant focus of this lens of having to deliver care primarily through the idea of weight loss and weight management really threatens to move us away from these principles. So we have extensive evidence that most people, for most people, weight loss is not sustainable. You might get some short-term gains. Usually it comes back. Weight cycling alone is linked to a lot of adverse health effects. And that weight-based medicine, as I've just presented, is actually preventing people from accessing any care they need, whether it's, for the flu or for mental health or for routine health maintenance. And we really need to kind of think about this dilemma and how do we reconcile this dissonance between wanting to be compassionate, to wanting to honor autonomy, to want to, have non-maleficence, and at the same time, diet culture just pushing us with this, monolithic drive to only talk about weight loss when we're presented with somebody in a larger body in front of us in an exam room. So where do we go from here? How do we look at these beautiful patients who are trusting us enough to walk into this space and sit in front of us vulnerably? How do we hold them closer? How do we hold them compassionately? How can we be inclusive for them so that they get the care that they need, regardless of their intention to lose weight? And so the model that is most common, at least in this area, is health at every size. Frequently, patients will refer to it as HAES. And I want to be clear that I am not certified in HAES. I am not like a HAES practitioner TM. I have not done the work to learn all of the kind of explicit things that I would need to be a HAES educator. But I am HAES oriented because I have felt this, and I feel this with all of my patients, regardless of their identities, that they have the right to exist exactly as they are. What would it mean if someone had the right to access healthcare with you, regardless of their intention to lose weight? What would it mean for you to deliver care and release the focus on weight loss as the solution for everything? So health at every size has 4 principles that I think really focus for us in terms of our individual practice, and then one more that is about kind of larger social justice movement within public health. So the first one is weight inclusivity, that we accept and respect the inherent diversity of body shapes, and that we reject idealizing or pathologizing of specific weights. The second one is the one that is around health policy, which is that we support policies that improve access and equalize access to information and services. The third is respectful care, where we begin to do the work. We acknowledge our biases. We work to end weight discrimination. We begin to dig into the weight bias that manifests in our professional lives and try to decrease it. And then 4 and 5 is what I really work on in my counseling and practices, which is eating for well-being and life-enhancing movement. The intent of HAES is to support the health behaviors of people at all sizes. So it's not anti-weight loss. I do want to clarify that weight loss may or may not be a side effect of HAES, but it's emerging as a standard practice in the field of the care of people with eating disorders. And it can feel confusing because, especially if you look on the internet, there's a sense of it as this kind of major social movement. But I want to be clear that I do think there are some specific weight inclusive treatment approaches that can really help when we are one-to-one in an encounter. And those are the two that I'm going to go over now. So eating for well-being. A lot of times, this is called intuitive eating. You might have seen this if you like Instagram or Twitter. This is around a lot. It's, again, becoming standard practice for people recovering from eating disorders. And the general principle is that our bodies are wired to know how to eat and how to respond to our needs. And it's really learning to trust our bodies, prioritizing our body knowledge over external rules like calorie counting and portion size. And so usually people who are working with an eating disorder or who are dealing with a lot of internalized shame about their bodies, really what toxic diet culture has taught them is to ignore their body's signals. They are really dissociated from all of the signals their body's sending. They've just learned to restrict, to ignore, to tamp down their hunger. And it turns into a very painful and dangerous cycle for them. And intuitive eating is finding a path towards nourishment, towards acknowledging appetite in a way that makes you stronger, that helps you trust that you're reading your body's signals, rather than this kind of external idea of only being allowed X amount of calories or specific bad foods, good foods, all of that. If anyone needs a list of intuitive eating aligned nutritionists, I'm glad to share it. Life-enhancing movement is the idea that when you talk to people about their weight, you don't want to frame it as punishment, and you don't want to frame it as a punishment for what they've chosen to eat. That physical activity is a celebration of what your body can do. And the joyful movement approaches through a path of pleasure. And when you emphasize pleasure, you're more likely to kind of sustain your body movement regularly. I think this is particularly important in the pandemic. We've just, although we are all living with an intense amount of privilege in this area and in the United States, we still have been dealing with a lot of restriction. Our bodies are kind of hardwired right now. Our gas tank is low in terms of dealing with more restriction and scarcity. And so if we frame things as punishment, if we frame exercise as a restrictive punishing activity, we're not going to sustain it. Our synapses are going to fire and just cheat code us over it. And so really framing for abundance and pleasure, what feels good, what is going to get your body moving, that's how you're going to kind of reframe yourself towards kind of joyful lifelong practice. And it's really interesting to sit with someone and just say, when was the last time you felt great when you moved? Even if it's in childhood, it was playing tag. When was the last time you moved and you just were flooded with joy? And to sit with that rather than doing a gym prescription, which they're afraid to go to because it's not fun, it doesn't feel good. And, it's a place where diet culture reigns supreme. So there's a lot of unlearning in progress. I'm doing it every day. And my patients are leading me every day in how to do better with all of this. And I think that, when I talk about these kind of big high level concepts, people sometimes are like, well, what am I going to do today? Like, sure, I'll go read about health at every size. I'll work on my scripts. I'll start looking into the data about all of these different approaches, but like, how am I going to sit in front of a patient today? Like, what could I do better when I leave? And so I want to say that even if you've done the work, you've done all the Hayes CME, you've learned about intuitive eating, you've gotten into right relationship with the way that you talk about weight in the medical setting, even when patients report satisfaction with kind of the medical personnel, even when they see a Hayes aligned doctor, or they have a doctor who is weight neutral and doesn't talk about weight loss without their permission, the equipment and facilities alone are often inadequate. And this can really contribute to negative experiences. So if you're going to do one thing today, what I would ask you is to take a deep breath and say, is your office set up to communicate to all patients that their healthcare needs will be met there without shame? Can every person in whatever body they are walk into your office and not feel shame? And I think that's a little bit of a difficult thing to kind of conceptualize. So I'm going to show you what we did in our office. And this has been through explicit feedback from our patients. So one is our waiting room. There are chairs in the waiting room that are fairly narrow with arms, so that it's really hard to sit in them if you have a bigger body. And so I have patients who at first had to be like standing, or I had a patient walk out of a specialist office because there was nowhere they could sit down. There was going to be a 30-minute wait, but they couldn't fit their body in these armed chairs. Versus having a chair or many chairs in your waiting room that are larger so that you can sit comfortably if you have a bigger body. Same goes for your exam room. Look at the chairs in your exam room. Are they narrow with arms, or are there larger chairs that don't have arms so people can position themselves comfortably while they're waiting for you? Do you have the right size equipment? If we're going to sit here and tell people about their blood pressure and that their blood pressure is because of their weight and they need to lose weight, we better be able to actually manage their blood pressure and not just assume they're hypertensive. And there are a lot of offices that don't actually have cuffs that fit my patient's arms. Do you have one size of gown? I've had patients who've gone to especially specialist office and have not wanted to have an adequate exam, even for things like dermatologists, where you want the dermatologist to see everything, because the paper gown's ripped. They couldn't get their arms to the sleeves of a normal gown, quote unquote normal gown. And our office has another size of gown, a larger one. They're very cozy. They fit even my 600-pound patients. And I have to say, one day we ran out of the smaller gowns and all we had were these larger gowns. And even the really thin people love them. They're very cozy and they cover you up. And so what if you had to pick one gown? Why not pick a bigger size so that everyone who walks into your office is respectfully draped when you are doing an exam? And this one's a little tender, but I'm just going to say it. I'm going to take a little bit of a risk. And this poster that is in a lot of the primary care offices that says, don't wait to feel great. And like most of the BMIs of my patients are in like hot red, is really triggering for my patients with eating disorders. I've walked in with people in tears when they've seen it. And I just want to ask, like, does this really help? Has anyone looked at this and like left feeling more motivated to take better care of themselves and not felt shame? Or the sign that we put up that says that your health is more than a number on a scale, that they don't need to be weighed in order to receive care today, or they can request to be weighed and not told the number. And the amount of people who take a deep breath and say, for the first time, I feel okay in a medical office. So let's talk about that, Pat. Let's talk about the mental health care. Let's talk about the colonoscopy. I trust that you're seeing me as more than a number because you actually wrote it on the wall. And it's been really meaningful for me to provide great and high quality care for my patients to just make this all explicit. And I just finally want to say that you're only as good as your team. And so you can be the wokest person on earth, you can have read all the stuff, you can have the awesome office, but if you don't have an MA, a nurse, a front desk partner who is doing the work with you and evolving with you, patients recognize that and they'll be out the door. And so my MA, Griselle Hernandez, is the first person that my patient sees and touches, and she does affirmative consent for everything. Do you want to be weighed? You don't have to. She knows how to take a blind weight. She knows how to communicate it with me. And patients feel so well cared for because they know that she and I are working as a team to be weight inclusive. So that's the end. Thank you for listening. I'm glad to talk in the chat or take questions. And I just want to say, I joined Newton-Wellesley because of the care first and what I see of the neighborliness, the compassionate, the attitude that everyone has towards patients here. And I think that a lot of the stuff I've talked about kind of aligns with how Newton-Wellesley wants to be towards patients. So I hope that some of the ideas that I shared are meaningful for you as you go forth in your own practice.
Thank you so much, Abby. That was terrific. Really eye-opening. There's one comment in the chat. I don't know if you can open up the chat if you want to comment on the comment there. We are coming up to the hour, but I'm sure Abby will stay on for a couple of minutes if people want to throw any comments or short stories into the chat or questions for her. Certainly those last couple of tips around the office seem like something all of us can kind of institute in our offices starting tomorrow. So thanks for those. Truly appreciate it.
So yeah, Dr. Finn, you asked about can metabolic improvement with healthy nutrition may occur without weight loss? Absolutely, I agree. And I think that there's a robust amount of data to show that weight loss may or may not happen with healthy nutrition, but metabolic improvement definitely can. And if you need some like data or like kind of official research studies on it, I'm glad to share it. Same goes with exercise, that there's enormous benefits to exercise regardless of an intention to lose weight. And yeah, I'm glad to share the list of nutritionists.
Yeah, great. Thanks. All right, seeing as there's no other questions or comments, it looks like there are some references as well. Certainly Abby is, on our email. You can get her through the partner's email, and we can see how that goes. I hope everyone has a nice weekend. It's a nice warm day out today. I know for a lot of people, it's going to be a sad weekend because it's the last weekend of football. I know my wife, Jen, is on this call. I know she's always sad when it's the last day of football and we have a whole season without football, but hope everyone gets to enjoy the big game. Hopefully it won't be too snowy on Sunday for folks. And we'll see you all back here next Thursday. We have a great talk by Dr. Alifas on sudden hearing loss. Abby, thanks again for a really wonderful talk. Hope everyone has a great day. Bye.